Hello, this is Dr. Eric Bricker. Thank you for watching A Healthcare Z. Today's training session is on how hospitals really work, clinical training for non-clinical healthcare professionals. Now, thank you so much for being here today. This is my favorite time of the week, is to be able to speak with all of you, or at least meet with all of you virtually. As always, if you leave a comment in either LinkedIn or YouTube, I can actually see it on my side. And so it would be super helpful just if we could do a quick mic check to make sure that you can see me and hear me okay. Sometimes you have to hit refresh in order to make sure that that happens. But again, for everybody who's just joining, this is Dr. Eric Bricker from A Healthcare Z. Today's topic is how hospitals really work, clinical training for non-clinical healthcare professionals. And we're going to do something a little different today in that we're going to spend time looking at pictures of hospital settings and going through those pictures in details, because I think the best way to understand how hospitals really work is to actually see them. Now, I think that this first picture is very appropriate, because what do hospitals have? They have people in white coats, maybe these people are doctors, looking at computer screens. So you want to know how hospitals work? Hospitals are all about people looking at computer screens. So of course, here they're looking at radiology images. And of course, this is a staged photo, because anytime you're looking at radiology images, the room is dark. Okay, so it would never be light like this. The shades would be drawn, it would be dark. So obviously for picture purposes, they have it light. But in IRL, in the real world, it would be dark. Okay, so now, many of you know me, but I just want to give you a quick background about myself. So again, I'm Dr. Eric Bricker. I initially started out as a hospital finance consultant, working at billing projects at the University of Kansas and the Cleveland Clinic and Yale Associated Hospital, a variety of other hospitals in America. Then went on to medical school at the University of Illinois, University of Illinois Medical School is in Chicago. Then went on to do my residency in internal medicine at Johns Hopkins in Baltimore. And then I actually initially worked as a hospitalist physician in one of the suburbs of Dallas that's called Plano, Texas. And so through my medical school and residency and working at a hospital as a hospitalist, like I sort of lived at the hospital. Like sort of an intimate. That was my office, if you will. That was sort of where I spent all of my time. So all of this is sort of firsthand knowledge of what I experienced while working in the hospital. I then went on to found Compass Professional Health Services, which is a healthcare navigation company. We grew that to over 2,000 employer clients, 1.8 million people that we helped navigate the U.S. healthcare system and their health insurance. That company was then bought by Alight Solutions back in 2018. And Alight's a very large company in and of itself. And when I left as a result of that transaction, I started making these A Healthcare Z videos, which many of you watch. Thank you so much for watching them. And it's a YouTube channel, and then I have them on LinkedIn as well. And then I am now also, I still make my A Healthcare Z videos, but I am now also the medical director for Simple Pay Health, which is an alternative health plan. And our first picture that we're going to go through today in terms of how hospitals really work is this is an ER emergency room, and this is a nurse's station at an ER. And so what I'm going to do is go through in detail kind of what are some of the things that you see here. Okay. So here, let me switch this just for 1 second. All right, now we're going to switch back. Okay, what's one of the first things you notice here? Phones with cords. Yes, that's right. In the majority of hospitals in America, you have to be on the phone a lot talking to different parts of the hospital. And a lot of those phones are just on cords. And so at the end of the day, like, one of the constant themes that we're going to be talking about here is just ways in which hospital clinical operations could be improved for the doctors and the nurses and the techs and the physical therapists and everybody else that's working at the hospital, because there's such a tremendous opportunity to improve the way that hospitals are run. And at a very basic level, shoot, This is the 21st century. Having a phone with a cord is not very helpful, okay? You need to walk around constantly. Hey, if you just had your own little like phone walking around the hospital that you could keep in your pocket, guess what? That would be hugely helpful in terms of your productivity. Okay, what else do you see down here in the corner? Post-it notes. The emergency room and hospitals in general are filled with Post-it notes. So it is, again, 21st century. We are not a paperless environment. There is gobs of paper in the emergency room, and it's like reminders, it's like leaving notes for other clinicians, etc. Tons of it is done through Post-it notes. What else do you note here? Like I said, that there's a lot of stuff that's done in paper. What do you notice here? A printer. Okay, what do you notice here? A fax machine. Yes, it's true. This picture is from Sonoma County, California, like last year in 2021. Okay, this is not some old photo that I took. All right. Now, okay, fax machine still alive and well in the hospital emergency room. Okay, then also here, you can kind of see it here, and you can kind of see here is papers in bins. Again, there's tons of paperwork and paper shuffling that happens at hospitals. Now, what happens with all that paper is, guess what? It tends to get discombobulated. Papers get strewn all over the place, et cetera, et cetera. So just know hospital clinical operations are still heavily paper driven. Now, what else do you note here? Scrubs, 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 scrubs. Okay, there's a little bit of a different color scrub. Everybody's in scrubs. So even the ER physicians typically wear scrubs. And what's my point here is that if you're a patient or a family member, it's actually very difficult to tell who has what role in the emergency room because everybody looks the same. It could be a doctor, it could be a nurse, it could be a tech. So just know that it's actually not particularly obvious when you're a patient, like what your job is as, so you walk into the room, you're like, oh, you're the doctor, you're the nurse, you're just the tech here to take my time, so it's like, it's really hard to tell because everybody looks the same. Okay. Then next, in the back here, we have a supply cart. So just know that, again, operationally, there's a lot of supplies. What are some of the big things they have? It'd be like face shields and gloves, and then also the disposable gowns if you need to go into a patient room. And we'll talk more about the gowns, gowning up later on, because certainly if depending upon the type of admission, then the doctors and the nurses and the techs, they actually have to gown up when they're going into the patient room. Okay. Notice too, the staff, largely older people, like I'll say middle-aged people. Like the majority of these people are probably, I'm going to guess and say over 40. So in general, again, you're going to find the average age of a nurse I shouldn't say average, the median age of a nurse in America is 52. Half the nurses in America are over the age of 52. So in general, they're older. Okay, notice here, pretty cramped, right? You got 1, 2, 3, 4, 5 people all working within about a 6 to 7 foot area of each other. So ERs are very cramped for the people that work there. Notice also that you have badges with lanyards. Okay, so these badges are super important because, of course, they've got, your identity on it. But in order to access things like, let's say, the medication room or different parts of the hospital, your badge, oftentimes it either has a sort of magnetic coat on it or it's got a swiper. So you pull it off the lanyard, it's like a retractable lanyard, and you swipe into these various places. So just know like that badge is super important, because if you don't have that badge, like you forget it at home or whatever, like it is like you can't get anywhere in the hospital or do your job without that badge and that lanyard. Okay. Notice here that this particular woman, she's probably a nurse. And notice here that she has sort of a CB radio that she's walking around with. Now, what's that for? That's for the ambulances to communicate with the ER. And the ambulances will communicate to say, hey, look, we're bringing, so-and-so in, and they'll give some, high-level information about this patient that they're bringing in, and it might be like a level 1 trauma patient, etc. And then they also, if the EMTs need to do something in the field, like administer medications in the field, like they might want to start an IV and start IV fluids if the person's blood pressure is low. They might even, if their heart rate is excessively high or excessively low, they might actually want to give them medications through an IV again in the field. They actually need permission from the ER doctor in order to do that. And so they will CB or radio into the nurse, and then the nurse will get, and it's all driven by protocols. And then the nurse will get the ER doctor on the phone, and they actually have to talk through that in order for that to happen, because it's considered practicing medicine in the field. And so it needs to be done in conjunction with the oversight of a physician. So at a basic level, there you go. There you've got a picture of an emergency room. Now, let's talk about then how people get into the hospital and the different, types of patients that are in the hospital. So you have both inpatients and outpatients and admissions. And oh, by the way, let me pause and say, if you have questions or comments, please put them in the description or the comment section, and I'll be able to see them on my side so that I can pause and answer them as we go through. Now, when a patient is at a hospital, they can have a variety of statuses. They can be an inpatient, which means that they're going to be admitted to the hospital. They can also, there's also something called an observation stay, where to a patient, you feel like you've been admitted, but it's also referred to as a 23-hour stay. And this is just done for billing purposes, because when a patient is in observation status, then the hospital doesn't get paid. It's actually it's almost like an outpatient. They get paid on a CPT basis, not on a DRG basis. And so a lot of surgeries and even short medical stays will be observation stays and not inpatient stays. And then there, of course, are outpatients. And believe it or not, gobs of services at hospitals are actually done as outpatients. So the majority of surgeries at hospitals are actually now outpatient surgery. So it's the same operating room, and there could be like a coronary artery bypass graft going on in one of the operating rooms, and that's obviously an inpatient stay. They're going to have to be transferred to the ICU after having the open heart surgery. But then you can have things like in literally the operating room next door, you could have a child who's having tubes placed in their ears, which is an outpatient surgery performed by an ENT. And so that's an outpatient surgery that's done at the hospital. Also, a lot of infusions are done at the hospital. You're never admitted. You're an outpatient. People come in for labs and for testing. It could be an MRI or a CT scan. So you could have hospital-based imaging. You could have a cardiac stress test that's done at the hospitals. Again, so there's a lot of activity that goes on at a hospital that's not even for inpatients. And again, this is an important distinction here, because only the inpatients are based upon what are referred to as these diagnosis-related groups, whereas the observation and the outpatient stays and the infusions and the labs and the testing, that is CPT code-based billing. Now, at a very basic level, that's important because for Medicare patients, their Medicare Part A covers hospitalization, but it only covers this. It covers the inpatient stuff. So if you're on Medicare and you're like, oh, well, Medicare covers my hospital stuff. Well, it's your Medicare Part B that's going to be covering your observation stays and your outpatient surgery and all that stuff. So that's CPT-based billing that's going to go on Medicare Part B. Guess what? Medicare Part B has a deductible and co-insurance. And so this is where people who have Medicare are like, oh, I was at the hospital, it should be covered by my Medicare Part A. And you're like, no, it's under Part B, and there's a significant out-of-pocket cost. This is why people get supplemental Medicare insurance to cover those out-of-pocket costs associated with a lot of their Part B out-of-pocket costs. Okay, next up. The way you get into a hospital is a variety of ways. So one of the most common ways is through the ER. So you come into the ER, you either walk in or you're brought in by an ambulance, and then you get admitted from the ER to the floor. There's also something called a direct admit, where a patient is seen in a clinic, and it could be a clinic like in a clinic building that's like literally attached to the hospital. or it could be a clinic, several miles away. And this is where the doctor sees the patient in the clinic and they're like, whoa, you need to be admitted. And a lot of times the doctor will be like, well, you just need to go to the ER. But that's not the best thing to do because it clogs up the ER. And the doctor knows that, like, hey, let's, perfect example, person comes in with a cough and they're actually fairly hypoxic. They have low oxygen level at the clinic, and like they have oxygen at the clinic and they need to put them on oxygen right there in the clinic. And you're like, well, you need to be admitted, let's say for a pneumonia. Like, I don't need to send you to the ER to make that happen. You can actually contact the hospital, and there's a person at the hospital who's referred to as the shift coordinator, who sort of acts as the quarterback for all of the admits coming in, but then also the transfers of the patients between the different floors. Let's say you get downgraded from the ICU to the floor, or your condition worsens and you got to go from the floor to the ICU. It's the shift coordinator that acts as the air traffic controller to make all that happen through the hospital. And so all hospitals have ways for clinics to contact that shift coordinator to be like, hey, I'm Dr. So-and-so in such and such clinic, and we got, Mrs. So-and-so in here who's hypoxic, and I need to admit her for a pneumonia. And you can do that. And then you just have the patient, the family member, drive them into the hospital and go to admitting, and they'll take you straight up to a bed and you can bypass the ER. So that's another way to get into the hospital, is a direct admit. A lot of people also have scheduled admissions, and a lot of times this happens for elective surgery. So like one of the big ones was going to be like joint surgery and spine surgery for total joint replacements, like total knees and total hips. A lot of times those are inpatient stays, let's say 2 to 3 days in the hospital. It's also an elective. A lot of the spine surgeries are elective spine surgeries as well, like a scoliosis surgery, or a major low back surgery, which would be like a laminectomy, or a major neck surgery, one of which is called an ACDF, an anterior cervical I'm blanking. ACDF. Anyway, it's where they go in, discectomy infusion. Sorry. It's been a long week. It's Friday. Anterior cervical discectomy infusion. And it's probably about a 2 or maybe a 3-day stay as well. So you come in as scheduled and elective. Okay. So then you would go straight to the OR. You go to the OR, waiting room, and then they take you to the OR, and then you get admitted, after your operation, directly to the floor. And then of course there's labor and delivery, where a lot of times the protocol is you would just go straight to the labor and delivery floor. And then if it's late at night, because more than half of babies are delivered late at night, you would go into the ER, and then the ER says, okay, well then, you don't need to be quote unquote seen in the ER. They just have you go straight up to the labor and delivery floor to have your baby. Once you're admitted, most hospitals these days, they make a distinction between, okay, what service are you going to go to? And that is, oftentimes, this is what it is an internal medicine physician that is assigned to the hospital and sees all of the medical patients on the floor, and they are the admitting physician, and they're the hospitalist. Now, they can also be admitted to surgery. So let's say, you've got the sort of the classic, ruptured appendicitis. It's an emergency surgery. They take you straight to the OR. You're going to be admitted after that. Well, then they wouldn't admit you to the hospitalist. The admitting physician would be the surgeon. Likewise, if you're a child, there's some hospitals that are children only, obviously, and then there's a lot of hospitals that have both pediatric and adult medicine. So you would be admitted to a pediatrician for children. And then obviously, if you're having a baby, you'd be admitted to the obstetrician gynecologist. Now, oftentimes there will be a consulting physician who is notified in the ER. Like if your major problem is that your heart rate is too fast, or your heart rate is too slow, or you're having a heart attack, they might consult cardiology in the emergency room to make cardiology aware. But still, the majority of the time, you're not admitted to cardiology. You're actually admitted to the hospitalist, who's the admitting physician, and it's the cardiologist who's on consult. Likewise, if you have like a bleeding gastric ulcer where you need to have an endoscopy to stop that bleeding, then the gastroenterologist would be consulted in the ER and perform the scope, maybe the same night that you're coming in, maybe the next day. But again, it would be the hospitalist who would be the admitting physician. Likewise, if you come in acute renal failure, or if you come in with, now here, if you come in with cancer, it depends upon the hospital. If you're an established patient with cancer, sometimes they'll admit you to the oncologist, or sometimes they'll admit you to the hospitalist, and then the oncologist, again, will just be on consult. Likewise, if you, let's say, have a kidney stone or an abscess in your kidney, they might admit you to the hospitalist, but again, it's the urologist who's on consult that will see you. Now, then you're admitted to different levels of care in the hospital as well. So you have what are referred to as the med surg floor, or just the floor. Now, on the med surg floor, again, you could have the hospitalist, and majority of them are going to be hospitalists. They're going to be the admitting physicians. The surgeons in general don't have as many patients that they are admitting through the ER, just because medical conditions are more common than surgical conditions. And then you can have on those floors, sometimes they'll have dedicated floors for telemetry, or sometimes they just have the ability to put you on telemetry on any floor in the hospital. And what telemetry is essentially when they put those EKG leads on your chest with the stickers and the wires, so that they can continuously monitor your heart rate while you are hospitalized. Now, why would you want to be on telemetry? So obviously, if you're having some sort of cardiac issue, like a heart attack, or tachycardia, where your heart is going too fast, or bradycardia, where your heart is going too slow, then they're going to put you on telemetry. And on these medical surgical floors, they have, to a certain extent, standardized nursing to patient, or patient to nursing ratios. And so on a medical floor during the day, typically it'll be about 4 patients to every 1 nurse. And then at night, because not as much is going on at night, oftentimes it will double, and there will be 8 patients to 1 nurse at night. Now, I've had nurses tell me that, look, even during the day on a medical floor, they'll have like 8 patients that they have to take care of during the day. And at night, it might even be more than 8. So there's only so much a nurse can do for a patient when they're spread across 4 patients or 8 patients. And this is a huge area of patient safety and concern and burnout for nurses, is with the shortage of nursing, that there have been more patients. In other words, the ratio has been increased for these nurses. And shoot, if you even go from 4 patients to 5 patients, what's that called? A 25% increase in your patients. And the problem is that if the patients, the degree of intensity of care and nursing that a patient requires is highly variable. So you could have 4 very quote unquote easy patients. So the nurses will refer to them as easy breezy or walkie talkie. So when they're giving a report to each other, they'll be like, oh yeah, the patient in bed 407B, they're easy breezy walkie talkie, right? So if you have 4 of those patients, it's not that hard. But if you have even 1 or 2 patients that is having, they're having delirium and they're trying to get out of bed and they're a huge fall risk, like it can be super time intensive. Look, someone said in the comments, try 15 to 1, right? So the patient to nurse ratio can be anecdotally much higher. Thank you for that comment, Special K. Then, of course, in the hospital, you also have the intensive care unit, the ICU. Now, at most community hospitals, it's just 1 ICU, but at much larger academic medical centers, or even just very large community hospitals, they'll have different types of ICUs. So they'll have a medical ICU for people who have, let's say, such bad pneumonia that they need to be on a ventilator. But then they'll also have the surgical ICU. Again, so if a person goes in for a CABG, a coronary artery bypass graft, after they have that open heart surgery, they have to go to the ICU post-operatively because it's such a major surgery. And so they would go to the surgical ICU. Now, again, in some community hospitals, they all go to the same ICU. And that's a little tough because if you're an ICU nurse, like the type of nursing you do for post-CABG in an ICU is very different than the type of nursing that you would do for sepsis or ARDS, etc. So that's why at very large hospitals, they tend to specialize their ICUs and have multiple ICUs. So of course, you also have the pediatric ICU. And interestingly, as soon as a baby is, so let's say it's a premature baby, if they're discharged from the hospital, if they ever need to be readmitted, they do not go to the neonatal ICU. That's what the NICU is. Okay, so that is the baby is delivered, oftentimes prematurely, has some sort of problem. They go straight to the neonatal ICU. Now, once they go home, if they have to come back because of some, even if they were born prematurely, they then go to the pediatric ICU. So there's actually a lot of very, young children, infants sub 1 years old that are in the pediatric ICU as well. And then, of course, at some incredibly specialized hospitals, so at Johns Hopkins, where I did my residency, they also had a neuro ICU because stroke care and post-brain surgery care, again, is highly specialized. And so the nurses and the attending physicians are obviously highly trained in whether it be a severe stroke care or post brain surgery care for like a glioblastoma, which is a very severe brain tumor after it's been removed. Now in the ICU, it's typically 2-to-1 nursing. So the care that is required and is so intense that one nurse only actually takes care of 2 patients at most. And then there's actually a stage in between, which is called step down, because it's a step down from the ICU, but it's actually a step up from the medical surgical floor. So these are people that are too sick to be on the regular medical floor, but they're not sick enough to get into the ICU. And there, the nursing ratio is about 3 to 4 to 1 patients to 1 nurse. Okay. Now, I, of course, cannot cover all of how hospital works in an hour. So this is just going to be high level. So I appreciate the patience that you've had with me for kind of going through so much detail. Let me pause here briefly and go to your questions. So thank you for asking them. All right. Thank you for your questions. I'm just reading through. This is a question from Beth. Thank you so much for your question. Are there not standing orders in place for the majority of scenarios so EMT doesn't have to call every action they want to do? Great question, Beth. The short answer is yes, but the protocols have in place scenarios where the EMT still needs to contact the physician. So, and honestly, when you're on the hospital side, the ER side of it, essentially what the EMT does is they're just going through their protocol and they're just asking for confirmation from the ER doctor. And like 9 times out of 10, the ER doctor is just saying, yeah, yes, confirm, go ahead. Would like to place IV. Yes, confirm, go ahead. Would like to give, let's say, epinephrine if the person's like their heart is stopped and they're coding them, et cetera. So certainly not all protocols require contact with the, and as you can imagine, it also varies by state. So this is not regulated at the federal level. This is regulated at the state level in terms of what the protocols are and what can or cannot be done by the EMT in conjunction with the ER. So thank you for that question. Henry, thank you for your question. Could you talk about common barriers to the discharge process from the step down floor? Okay, so first off, just so that we all get on the same page, because you're staying in the hospital, it's not referred to as a discharge. It's called a transfer. And so every hospital is different, but it typically is based upon your vital signs. So typically, let's say if you have a consistent heart rate in excess of 100 or 110 beats per minute, and your blood pressure is too labile. In other words, your blood pressure is going up too high or it's going down too low, or then you would sort of automatically need to go to step down. Okay, now that was at a highly protocolized hospital like Johns Hopkins. At community hospitals, they don't necessarily have those protocols in place. Likewise, if you need to give certain medications, so like if your heart rate is too fast, oftentimes you're given a medication called diltiazem, and it's given via a drip, a constant infusion. And the protocol is such that, you're not really sick enough to have to be in the ICU, but the protocol is such that you are not the regular medical floor, you're not allowed to give that drip on the regular medical floor. You have to be in step down in order to give that drip. So to your question, when can you be transferred from the step down back to the regular floor is okay. Well, once your heart rate's under better control and you're either taking IV push or pill diltiazem, then you can go back to the regular floor. And you don't have to go from step down to the floor before you're discharged home. There's actually a lot of patients who sort of get better so quickly that they can go straight from step down to discharge. All right, thank you for your questions. For the sake of time, I'm going to move on now. And this is a what would be considered a regular patient room. I would say this is probably a private room. You don't see any other patients in there. And notice here, you've got tons of tubes and wires. So just know that what does hospitalization involve besides lots of clinicians looking at the computer? You got lots of tubes and wires. Okay, so what are these? So this is a woman who had some sort of respiratory problem, and she might have had COVID or pneumonia or a COPD exacerbation, that's emphysema. And you can see you can barely tell, but she's on a nasal cannula of oxygen. And the oxygen tubing is right there plugged into the hospital wall, right? So this is where some hospitals, and certainly hospitals in India, had a problem because they were running out of oxygen. So one of the most important therapeutic interventions that people get at the hospital is oxygen. I mean, shoot, obviously just oxygen, like liquefied oxygen, which then is turned back into a gas, which is given to people. I mean, it has saved so many lives. To just modern hospitalization with the delivery of oxygen is awesome. I mean, we take it for granted. We're like, oh, we'll just put you on oxygen. I mean, it is just, okay, so there's different ways to give oxygen. You got the nasal cannula, which just goes in, two little things into the nose, which actually can only deliver about an additional, let's just call it 10 to 15% oxygen. And then here, you can barely see it on the tray, is what's called a face mask. And believe it or not, when you have a face mask, and then with this bag here, it's a special type of face mask that's referred to as a non-rebreather, which allows you to get the oxygen concentration up to about 40 to 60%. And then you have a machine back here that is referred to as either a BiPAP or a CPAP machine. And you can think of that as like a ventilator light, where it actually, like in the case of BiPAP, which stands for bi-level positive airway pressure, they actually put a mask on your face and they strap it to your face very tightly so that the oxygen cannot escape around the mouth, and it actually forces air into the lungs. So for people who are having a hard time breathing, it helps them breathe by forcing air into the lungs when they take breaths in. And it also helps open up the airways that might be clogged with either fluid or mucus or pus because of a pneumonia or a CHF exacerbation or a COPD exacerbation. And so there are lots of people, especially with COVID pneumonia or even just regular pneumonia, that are they don't need to be on a ventilator in the ICU, but they might need to be put on BiPAP. So the fact that this person has a BiPAP or a CPAP in the room, I bet you this is step down. You typically can't put a person on BiPAP or CPAP on a regular floor. You typically have to do that in step down. And then you sometimes put people on BiPAP or CPAP in the ICU as well. Okay. So next up, you also notice this little contraption here. So what is this? This is most likely a bedside ultrasound. So there you can see the little screen, and there's a little ultrasound probe, and there's the cord kind of connecting and it's on wheels, right? You can wheel it around. And so what's one of the common reasons and ultrasound obviously is used, everybody knows it for like pregnant women to like look at the baby, but here, one of the most common reasons to use bedside ultrasound is for the placement of a central line. And there's different types of central lines. And one of the most common central line, which is like an IV, except it has a super long catheter that goes through the vein that gets snaked all the way to the heart. And what that does is it makes it very secure. So the problem with IVs is that they can fall out or they can blow the vein, or the vein literally ruptures. Whereas when you have a central line, it's actually sutured in place and it's very stable. And it also immediately delivers the medication directly to the heart so that it can be diffused throughout the bloodstream very rapidly. And so a lot of people who are in unstable clinical situations are given these central lines. What a central line also allows is to draw blood without having to stick them with a needle. So if you just have an IV, you can't do a blood draw through an IV. You then have to stick them separately with a needle. And the phlebotomists are going around the hospital doing a lot of the needle sticks for the lab checks, which are often multiple times a day. And so just know that the use of PICC lines in hospitals has dramatically increased, even since I did my residency, 2004 to 2007, which is good and bad. Okay, so one of the good things about it is obviously because it's more stable, you're less likely to lose access. And when you lose access, you can't give IV fluids, you can't give the IV meds. And so people like miss their medications when their IV is problematic. So that's a positive. A negative is that central lines, including PICC lines, can get infected. And so it's much more likely for you to get a bloodstream infection with a central line, whereas with an IV, you really don't get bloodstream infections with an IV. You might get infected in the skin around the IV, but you don't get as severe bloodstream infections like you do with central lines. Okay, so now what else do we have here? We've got the whole bed is on wheels because of course when you're in the hospital you don't stay in your room, you get wheeled around the hospital constantly. And guess what, you get wheeled around in this massive bed, and guess what, that bed is super heavy. So I will tell you that not only as a resident but even as an attending physician, like I would totally like wheel people around because and the nurses have to wheel people around, and they have what's called patient transport, where people's job all day long is just to wheel people from their rooms and down to imaging and to various departments to get various tests and procedures done. And the problem is that the transport people, again, it kind of comes in waves, and like you can't get the test done until the transport person comes and gets them. But if the transport people are busy, then literally the person might have to wait for hours. And then the people at the testing place are like sitting there twiddling their thumbs waiting for the patient to come down. So to like, frankly, and again, this is another theme, is that the processes in hospitals are so complex and frankly have such frequent breakdowns that it requires sort of the heroic efforts by the techs and the doctors and the nurses and even the transport people themselves to constantly come in and like save the day. So I would be like, hey, why hasn't so-and-so gotten their abdominal x-ray yet? Well, transport hasn't gotten here. And I'm like, well, shoot, like, I don't know if their ileus is getting better and I can potentially, remove their nasogastric tube, or if their ileus is getting worse until I can get them, down there for that abdominal x-ray, or maybe even diagnose if they have an ileus versus a small bowel obstruction. And like, I'm busy, I'm seeing patients, and it'll be like 6 hours later. I ordered this thing and it's like 2 p.m. Like, what's going on? Where are the results? And they're like, oh yeah, transport hasn't come yet. And I'm like, oh no. So I'm like, forget it. So I would actually like go myself and I would transport the patient just to get it done, because it would totally like slow down and clog up like and it would prolong their stay. And then patients get backed up in the ER and they can't get admitted. So like, and then when you do that, of course, it's not just easy to like, you can't just like unhook all this stuff and then wheel them. They still need their oxygen. So what do? You got to find an oxygen tank. You got to put the oxygen in the tank, and the oxygen tanks are heavy. You can't see it because it's obscured by the sheets, but you got to put the oxygen tank underneath the bed. You got to disconnect the oxygen from the wall. You got to connect it to the oxygen tank. You got to find an oxygen tank that has enough oxygen in it. There's gobs of oxygen tanks. You're like, oh, this thing's empty. You got to take it back. So anyway, what's that called? A lot of work. All right. Now, notice too, the gobs of bedding that this person has. Okay, just know that patients in general at the hospital have gobs of bedding on them. Why do they have gobs of bedding on them? Because hospitals are kept intentionally cold, because if you keep a hospital cold and dry, it decreases the amount of mold spores in the hospitals. So I'm not against keeping hospitals cold and dry at all, okay? Like, to the extent that like you can prevent fungal infections in patients by keeping the hospital cold and dry, so be it. But what that means is that the patients are typically very cold. And like the typical temperature in a hospital, it's like in the 60s. I don't know, maybe 68 or something like that. And you'll constantly see, even in the summer, a lot of the nurses are wearing sweaters. All right. Now, what that means though is that from a physical exam perspective, you've got all these cords and you've got all these tubes and you've got all this bedding. And so you, as a nurse or physician or whatever, you have to make a conscious effort to get them out of their bedding so you can actually examine them. And like, that's super important, because what do you identify? You identify bed sores on their ankles and on their sacrum, which is their low back, kind of right above their butt. Like, and that's where people hide in their beds. And one of the most important things about patient care is, and being diligent, like a diligent nurse who does a diligent assessment, this is one of the most important things about nursing, is that the nurse is diligent in doing his or her assessment, and that the doctor, when they're doing their exam, is diligent in his or her exam, because it takes effort to undo, and the patients don't like it. They're like, I'm freezing cold. I'm like, listen, I get it, but like, I gotta examine you. All right. So just know that that is one of the things. Now, notice all the getup that this particular, let's just say, nurse is wearing. You got the booties, now this is all disposable stuff. Maybe they'll reuse the face shields, but a lot of this stuff, you just use this once when you're in the patient room, and then there's a special sort of garbage can that you put all of this in, and that's for something called contact precautions. So just know there's gobs of physical waste at a hospital, and it's because the person is infected with a particular type of bacteria or virus. In this case, these are bacteria. One is called C. diff, which is Clostridium difficile. It causes diarrhea. It's a nosocomial infection. You really pick it up in the hospital. It can be transferred from patient to patient. Then there's MRSA, which is methicillin-resistant Staph aureus. So that is which is very common, by the way. Actually, the majority of Staph aureus is actually now MRSA. Like 60% of Staph aureus is now MRSA, not methicillin sensitive. So that means that, like, it's harder to treat with antibiotics. So you put on contact precautions for that. Then there's vancomycin resistant enterococcus. So enterococcus, again, is a GI, or it could be a bloodstream infection that's resistant to a very strong antibiotic that's called vancomycin. So anytime somebody is infected with one of these particular bacteria, they're put on contact precautions, and it's a total pain because you got to like gown up and then gown down every time you go in. And so guess what happens? Like, there's not 100% compliance with gowning, okay? So people will totally like go into rooms and not gown. And then two, it also causes people to not want to go into the patient room. So like, I'm not saying that like that still don't get care or whatever, but just know that there's gobs of waste and it's a huge hassle. And at the end of the day, it's like, it causes barriers to patient care, because the patients don't necessarily get as much face-to-face time because it's so cumbersome to get into their patient room. So again, let me pause here and look at your questions and comments. Thank you so much for them. Special K from YouTube says, clinicians are becoming increasingly less bedside these days, tech-enabled monitoring primarily being done from the nurse's station. This is a great point. So when you're in the hospital, you don't actually spend a lot of time with patients, and we're going to get to that on a future slide. So just know that, like, and this is a huge job. Not only is it a patient care issue, but it's a huge job satisfaction problem, because doctors and nurses and even the techs, like, we went into medicine because we like spending time with people. Like, we don't like looking at computer screens. We don't like filling out paperwork. Like being with people is what is satisfying about the job. So, and I'll say this on a future slide, that if there are things that can be done from an AI and from a machine learning perspective to actually decrease the burden of the paperwork and the EMR, such that the clinicians can spend more time with the patients, then that not only is better for patient care, it's a huge job satisfier. There is not a doctor, nurse, tech alive that says, I just love looking at my computer screen all day. I just love filling out all this paperwork. No, everybody hates it, but they like spending time with patients. All right, next slide. So let's go through some of the different departments in the hospital. You've got radiology, where you've got CTs, MRIs, X-rays, PET scans, and GIs. And GI radiology. So that's like where you swallow contrast, like barium, and then they take X-rays of the barium to see how it's flowing through your gastrointestinal tract. That's done through the radiology department. Then there's interventional radiology, which is where they actually do, and interventional radiology actually looks a lot like this. So this is actually a cardiac cath lab, but interventional radiology looks the same way. This right here is what's referred to as a C-arm, where you can take actually movies with an x-ray. You can barely see it, but this is an actual TV screen where you can see a movie. And this is where the interventional radiologist is using the imaging to stick drains in like abscesses to drain the pus without surgery, or to take biopsies, let's say from a part of the piece of the lung, and they're using the imaging to guide where the needle goes into the lung to take the biopsy, or place what's referred to as an IVC filter, which is an inferior vena cava filter, which is a very common procedure at a hospital. When people have what's referred to as a DVT, a deep vein thrombosis, which is a blood clot in their legs, it breaks off and then goes to the lungs, which is then referred to as a pulmonary embolism, and that is potentially lethal. People die from pulmonary embolisms. And not everybody who has a DVT and a pulmonary embolism requires an IVC filter to basically, if any more clot breaks loose from their legs, the filter in their large vein of their abdomen actually catches that blood clot before it then travels further to the lungs, preventing the pulmonary embolism. So I won't get into detail anymore about that, but just know that that's a common procedure that's done by the interventional radiologist as well. And then, of course, there's cardiac catheterization. This actually is the cardiac cath lab, and there's most likely the cardiologist here. There's actually a patient underneath this blue drape. This person here is called the circulating nurse, and this person could be another cardiologist or could be an assistant or a PA. And this is where the person lies flat and they actually enter the person's artery through their groin, and then they snake a catheter up through their artery into the left side of their heart. And that's where they can actually go into the coronary arteries to do balloon angioplasty, where you open up a blockage and then you put in a stent, all done through the catheters here. And then you can monitor, they have them on an EKG or telemetry, so that they can constantly monitor how the heart is electrically functioning while they're doing these procedures. So obviously for things like not only angioplasty and stents for heart attacks, but also in what's referred to as the electrophysiology lab or the EP lab, which is sort of a specialized heart lab where they'll do ablations for a condition called atrial fibrillation, where the heart is just beating erratically and too fast, and you can actually burn small areas of the heart that are electrically defective, if you will. And by destroying that electrically defective part of the heart, again, a microscopic level, then you can actually stop the atrial fibrillation from happening. That's a very common procedure. And then you also have pacemakers that are put in the EP lab as well. Another department would be endoscopy. This would be where the gastroenterologists are doing the upper endoscopies, which are referred to as EGDs, or the colonoscopies. Then, of course, there's the operating room, which again is mostly outpatient. And then you have inpatient surgeries for joints and spine, emergency surgeries like ruptured appendix, cancer surgeries like on tumors, coronary artery bypass graft, valve replacements like aortic valve replacements. A AAA is an abdominal aortic aneurysm, so that's a very significant vascular surgery that's performed on an inpatient basis. There's cardiac stress testing, so this is where the nuclear stress tests are done in the hospital. There's, of course, lab and then phlebotomists. So sometimes the nurses do their own blood draws, but typically they have specialized phlebotomists where all they do is go around drawing blood all day long. Now, there's also, of course, the pharmacy, and then there is the blood bank. Again, sort of similar to oxygen. Countless lives in America have been saved because of blood transfusions. And so all hospitals have a blood bank because you have to be like matched to the right type of blood, and it's frozen, and they got to thaw it. And so all of this, the blood work, and a lot of the medications, and the blood is actually transferred through the tubing system. And everybody who works in healthcare needs to understand the tubing system. So you can barely see it right here, but here's the tubing system. Here's how you transport stuff around the hospital. Now, sometimes people go around with carts, etc., but a lot of the stuff is transferred via the tubing system. And why is that important? Because stuff is constantly coming and going. You can both receive things and send things through the tubing system. And you like push a button for like where you want to send it to. Now, the problem with the tubing system is that things will sit in the tubes after they've been tubed to you. Let me give you 2 examples. Things will be tubed to the lab, and a lot of times they'll sit at the lab before they actually get processed. And for certain blood samples, if they sit for too long, for like a lactate, then you get an inaccurate reading. Likewise, a lot of medications are tubed to the floor, and they actually have protocols for how frequently the tubing system is checked. Or sometimes they don't have protocols over how frequently the tubing system is checked. So you can go by the tubing system and be like, oh, look, there's a tube with something in it that's been sitting in the tubing system for a long time. And I'm not saying anybody's lazy, but they're busy. And shoot, that could be a stat medication that the physician ordered electronically that they want the patient to be given like rapidly. And believe it or not, a lot of hospitals have protocols where stat literally means within 1 hour. So like, and a lot of doctors don't know that. They're like, oh, stat, that means they're going to get it right away. No. If the medication is not on the floor, it has to be tubed it has to be filled at the pharmacy, tubed to the floor. The nurse has to get it out of the tubing system. They got to give it to the patient. And like, that oftentimes does not happen within an hour. So honestly, one of the things that I would do is if I ordered something stat, I would then walk to the pharmacy, be like, I need this filled now. And they would fill it for me. I would walk it to the nurse on the floor and be like, I just ordered this stat. And typically it would be like an antibiotic for like a person who like just had their infection identified. And frankly, their heart rate was kind of high, their blood pressure was kind of low, and they were becoming septic. And so the sooner you got in those antibiotics, the better. I'd be like, look, you need to hang this now. Like unless you got an emergency going on with some other patient, like I need you to hang this right now. And I'd be nice about it. But just know that, again, from a process perspective, there are major breakdowns constantly. Again, it requires the heroics. I'm not saying I'm a hero, but it requires the heroics of the nurses and the docs and the techs to constantly make up for these breakdowns in processes at the hospital. All right, moving on. Patient room, departments, and of course, nutrition, the food. We got to talk about the food. Now, the important thing about nutrition is the lack of nutrition, what is referred to as an NPO, nothing per oral, or none per oral. Patients are kept NPO and cannot eat constantly at the hospital. So you want to talk about hospitalization? Let me tell you what hospitalization is all about. Hospitalization, you constantly get interrupted, you can't get any sleep, and you can't eat. And we wonder why the elderly patients get delirium in the hospital, okay? So this is not as much of a big deal for younger patients, but it's very, very common for the elderly to have an altered mental state where they get confused. And I literally saw a guy once who constantly thought that his call bell was a fishing pole, and he would literally throw his call bell across the room because he was like casting because he thought he was fishing. And oh man, now we're getting spammed. All right, so forget this. I'm gonna try to block this particular user, so I apologize about that. All right, now, so just know that people are often hungry and sleep deprived because they're kept NPO for various tests and procedures, and like if what happens is okay, your tests, your procedures in the afternoon. Well, you're kept NPO after midnight, which means you go from not eating anything, let's say at 8 or 9 p.m. till like 3 in the afternoon, and it's very common for your test or procedure to get canceled. So there you go, and you've waited all day and you can't eat, and then like you got to go through it all over again because they move it to the next day. So it's miserable. All right, now we have a floor nurses station. All right, so now I showed you the nurses station for the ER. Now I'm going to show you the nurses station up on the floor. And you've asked questions. I'm going to pause briefly at the end to answer them. What do you see here? Middle-aged women doing paperwork, right? What is a floor? What is the definition of a floor at a hospital? A floor is what is the definition of a nursing station at a hospital? Middle-aged women doing paperwork. Okay, listen, and I'm not trying to be disrespectful to the male nurses out there, but at the end of the day, 90% of nurses in America are women. And again, I said the median age of a nurse is 52. Like, and why is it 52? because young people do not want to become nurses. And this is not any sort of incrimination of the young people. They don't want to become nurses because the job is incredibly unpleasant. It is super hard. It is undesirable. Like, again, these nurses right here, are they smiling? No. They don't like this. They like being with patients. They don't like what they're doing right here. Okay. So just again, if there is a way, now what are they doing? What is this? What is this notorious paperwork that they're doing? Much of nursing is protocol driven. So they've got these protocols, much of which that are on like paper. Like there's a protocol for the IV, there's a protocol for DVT prophylaxis, there's a protocol if somebody fell, there's a protocol for all sorts of things. They have oftentimes the electronic orders are printed out. So you have electronic order entry, but then they print out the orders. So they're not all the orders are actually in the compute. They're in the computer, but they then print them out on paper as well. And then they have to chart their assessment. So just like the physician is doing a history and physical exam every day on the patient, the nurses are doing that multiple times a day. And so they're charting. So again, if you could use AI and machine learning and natural language processing, I mean, we have this thing called Dragon that the physicians use to dictate their notes. If you could have all the nurses verbally do their protocols and not have to deal with it, be like, could you just, be able to talk into something and just be like, look, could you just pull up the protocol that we typically do for DVTs? And there's so much that you could do verbally on that would make their job so much easier so that they don't have to sit down at the nurse's station. And again, here are the patient rooms. And let's say this is a regular floor during the day, and you got nurse, do 3, 4, you got 5 nurses. Each one of these nurses has about 4 patients, let's say. So you've got about 20 people in rooms around this nursing station. All right. Now, what else? Oh, restraints. People are restrained. Again, these delirious elderly patients, they try to get out of their bed constantly. And what do they do when they're delirious and they get out of bed? They fall. And so you literally have to restrain them and like put them in these soft restraints or this vest that's called a posy. And guess what? You got to fill out paperwork for that too. I'm not saying that having a protocol for that. I mean, you don't want to like imprison people in their bed, but like you also don't want them falling. And so to the extent that you can actually make the protocol using AI and ML and natural language processing just so much easier for the nurses to have to fill out, that would be great. Okay, now patient rooms, talk about that. Okay, this right here is the med cabinet. So on a floor, only the nurses can give medication. So you've got a lot of techs as well, but in order to actually give the pills and administer the medications, IV, like that can't be delegated. The nurse has to do that. All right. So that's oftentimes it's called the Omnicell, just because Omnicell is the company that makes a lot of these medicine cabinets. So that's where and it's locked. Again, you got to use your badge in order to badge into this thing. Okay. And then you got the unit clerk. There's the unit clerk right there. And so interestingly, for some reason, unit clerks at a lot of hospitals, they wear these vests, right? So at the majority of hospitals where I've worked, the unit clerks also watch vests. So it's like a common way to distinguish the unit clerk. Now, here's the interesting thing. There's typically a unit clerk during the day, but there's not typically a unit clerk at night. And so the problem is that these nurses then have to do their own job, plus they have to do the unit clerk's job overnight. And my wife is a nurse, and she was a floor nurse, and she was also a night nurse. And so I know all about night nursing from my wife. So it's fantastic to be able to have her and all the education she's done with me about night nursing. Okay, next up. What do you have here? The quality reporting. Of course, every floor has these various charts and graphs and quality reporting. And so at the end of the day, you would see these things, and like, I'm not sure, at the end of the day, I'm not sure the quality reporting is ever paid attention to by the clinicians. I'm not picking on these nurses, but like, even like the doctors, they wouldn't look at the quality reporting. So just know that there is a lot of like, Excel spreadsheets and blah, blah, blah. And they post this stuff, but like, there's not necessarily, like, just because you post it doesn't mean it changes behavior. So I'm sort of being facetious here at the end, but like, just because you post the quality reporting, like, it doesn't mean that it actually leads to behavior change and actually improving the quality. And of course, this may be a Bible, And hospitals also have chaplains as well. And one of the, obviously people have spiritual needs at the hospital. If they're Catholic, they might have to be issued last rites if they are on the verge of death. And so obviously attuning to the spiritual needs, regardless of your religion, at the hospital is super important. And they have, again, not all hospitals have these folks available all the time, but there oftentimes are chaplain services at the hospital as well. All right. And the last thing that I'll point on here is just the workflow. And my only point around the workflow and the EMR, at the end of the day, like the EMR is just so hard to look at. Like the user interface for the EMR is just brutal. There's not an EMR out there that just doesn't have a brutal user interface. And so just know that the majority of clinicians, like nurses and doctors at the hospital, their eyes are not on patients. Their eyes are on abstractions of patients. So when they look at a patient, this is what they see. When you're in a hospital, you are not you. You are this. This is what they see of you. And it really, again, like, I don't think it's good for patient care. Like, it's really, like, it's a huge job dissatisfier. Like, every doctor and nurse hates looking at this thing. Okay. Like, that's not why they went into they weren't like fat. They're like, oh, I can't wait to look at an EMR for the rest of my career. Right. So again, to the extent that you can get people away from this thing and to the patient bedside, the better it will be. All right. Now, I'll have to go back and do another session to cover all these things. All right. So, final thoughts. Hospitalization, hugely complex interplay of people, process, and technology. There's a huge opportunity. If there's any entrepreneurs watching here, there's a huge opportunity for industrial engineering expertise applied to the hospitalization setting. We've applied industrial engineering wonderfully to other areas of our economy, and it would be wonderful to apply better industrial engineering to our hospitalization. There needs to be motivation to do this. It's not an issue of skill, it's an issue of will, whether it be through competition or regulation or both. I mean, we need to have an army of industrial engineering expertise to frankly help us out on the hospitalization side. The massive size of hospitals makes change super hard, okay? All these mergers have made these hospitals enormous. They have like 23,000 employees, 50,000 employees. So any sort of clinical process change is so slow and it's so hard just because these hospitals are so big. So maybe they just need to be smaller, because then you would also give patients and nurses and docs and staff members also greater choice in where they work. Like, if you don't want to work at this hospital system in this particular town, what are you going to do? You don't have a lot of options. So to a certain extent, and this is an extreme suggestion, but maybe to a certain extent, these hospitals just need to be broken up so that there can be more competition, frankly, so that the employees have more choice in terms of where they can work and the patients can have more choice in terms of where they go. And then again, we see all this technology in terms of medical devices and pharmaceutical technology. We really need labor-saving technology in healthcare. Labor-saving technology is a huge opportunity in healthcare. So with that, let me go here very briefly to the questions. Thank you for asking them. And one of the questions here is from a LinkedIn user. It says, can you please comment on materials from reconstructive plastic surgery? That's a great topic. I'd say that would have to be another topic for another day, just in terms of like OR operations and how that works. But thank you so much for your question. And there's just a lot of positive feedback here in the comments. Thank you so much, everybody, for all your encouragement. Thank you so much for being here. Again, you are my partners in making healthcare better. Like, I need your help. And so I really appreciate you watching. And please feel free to email me if you have any questions or comments or feedback at ericb@ahealthcarez.com. If you want to get on my email mailing list with it's almost 3,700 others, you can also just email me and I'll put you on that email list. If you just want to connect with me on LinkedIn, I would love for you to do that as well. And with that, just have a fantastic rest of your Friday and a great weekend. Bye now.